Hello, everyone. Nice to finally meet most of you, and hopefully, you guys are watching this at a good time. My name is Dr. Amar. I am an emergency medicine physician, uh, and what I'm going to do is I'm going to go through Dr. Sattar's lecture on autoimmune disorders. The first part being about how the body tries to stop autoimmunity. Um, I'm just going to, he does a really good job presenting this lecture. I'm just going to give you some more photos that I think or diagrams that are more helpful, maybe give you some clinical anecdotes, and hopefully clarify a few things. So, watch his lecture first before you watch this. Okay. So, immune mediated damage of cell tissues, called basically autoimmune disorders, have a 1 to 2% prevalence. They're very common. You're going to see this all the time in your clinical practice. I myself have an autoimmune disorder. I have psoriasis. It attacks my skin, so I get plaques. It attacks my joints, so my hands, it hurts. And it gets worse as time has gone on. And we'll kind of explain why it's getting, my psoriasis is getting worse, unfortunately. Um, Basically, we make self reactive lymphocytes, meaning lymphocytes that attack our cells all the time. We make them all the time. You have them in your body right now. But thankfully, we have mechanisms that stop them from destroying our own tissues. And when those mechanisms break down, we get diseases. Obviously, that's what pathology is. Pathology is when normal physiology and normal things break down, and now we have problems. So, first, let's talk about how things should be going normally. Okay. Normally, we have three checkpoints. We have central tolerance, we have peripheral tolerance, and we have regulatory T cells. So this is how the body prevents itself from attacking itself. Okay. So let's start with central tolerance. Okay. So central tolerance has two steps: positive selection and negative selection. So on the left, you'll see here Dr. Sattar's drawing. I put this diagram in because I thought it was a little bit more clear. But basically, the stem cell, the original T cell comes from the bone marrow to the thymus right here, right? And babies, remember, have really big thymus. You can see a thymic shadow on X-ray, but that's beside the point. So the T cells, T for thymus, T for T cells, comes and in the cortex, which is the outside of the thymus, you have it comes in as a double positive, meaning double positive has CD4 and CD8, CD4 and CD8, double positive. And then that becomes single positive. It becomes single positive by something called positive selection. Positive selection means if you do something, then you live. Negative selection means if you do something, you die. Okay, so step one, positive selection. So the double positive cells, the CD4 and CD8, undergo positive selection, and then they become single positive. The positive selection is they have an antigen. The antigen is bound to an MHC, and it's presented to the double positive cell. And if they can bind it, great, they live. If they can't, then apoptosis. Now, then you have single positive. Then that becomes single positives, and into the medulla of the thymus, it undergoes negative selection. Okay, so negative selection is basically, can they bind self antigen that is on dendritic cells or medullary epithelial cells? So, can the MHC2 bind to CD4, or the MHC1 bind to CD8 that has our self antigens on there? So this is like our stuff that's being presented to these cells, and if they bind it, they die. If they bind it too tightly, I should say, they die. If they bind it medium tightly, medium affinity, then they become regulatory T cells, which we'll talk about in a second. And then obviously, if they have low affinity, they don't bind it. Great, they pass negative selection. They can go on and they can live. Okay. Um, this next slide is the same thing, but now when we want to talk about ARE mutations, AIRE. Dr. Sattar brings this up because it's a great way to test a lot of things. Okay, so the medullary epithelial cells have a transcription factor. Remember, a transcription factor is something that allows certain genes to be expressed. Okay, and this transcription factor, this ARE, takes it basically allows the presentation or expression of self antigens onto the surface of the medullary epithelial cell. And therefore, when the CD4 or CD8 cell comes along, and if it binds it, then obviously it undergoes negative selection. Now, if you have an ARE mutation, you don't have that transcription factor that presents self antigen. You can understand how a lot of, unfortunately, self attacking lymphocytes can get bypassed this step and unfortunately, that's how you can get autoimmune disorders. So the area mutation results in autoimmune polyendocrine syndrome. Okay, so this causes hypoparathyroidism, right? So the thyroid gland has these little parathyroids. The parathyroids, um, regulate calcium, right? It can also cause adrenal failure. We're going to talk about the adrenal glands, but they make a ton of different hormones. And then it causes chronic candida infections. Candida is basically the white, it's like a white yeast looking infection, right? That you can get in your throat, that you can get in your vaginal area. Um, so yeah, so basically, if your medullary epithelial cells are not working, which is the case in the ARI, then you're just not going to have a proper central tolerance. Okay, we're going to talk about this FOXP3 in a second, so just keep that in mind. I accidentally put it on this slide. So let's going on to the next slide. So now let's talk about the B cells in the bone marrow. How do they do central tolerance? We're still on central tolerance. Okay, so now we talked about the T cells. Now let's talk about the B cells. The B cells can have two things can happen. They can either get deleted or they can get receptor editing. They don't have positive selection, they only undergo negative selection. So the dendritic cells present self antigen, meaning basically parts of ourself, to these B cells. If they bind, they die. If Or they get receptor editing. Okay, so receptor editing happens through the re-expression of the RAG genes. A RAG is like a cloth. I don't know if you guys have heard of rags, but basically they're just like a small little washcloth that you use to clean something, right? So that's how I remember it. Oh well, if you fail negative selection, you use the rag to clean up the B cell, and now the light chain on the B cell has been changed. So you can't change the heavy. Look at the heavy chain. The heavy chain is too big. You can wipe the light chain with the rag, and then therefore you can get receptor editing, and now that B cell can go on. Okay, so thymus T cell, bone marrow B cells, or both for central tolerance. Just remember these mechanisms, draw them out. They come up pretty fairly often. Now let's talk about peripheral tolerance. So we talked about central. Now we're going to move on to step 2, which is peripheral. Now, if something gets past the central tolerance, hopefully it gets picked up in the peripheral tolerance, right? This is our second checkpoint. So in this situation, we're going to talk about CD4 cells. CD4 cells have T cell receptors, TCR, and CD28. Okay, again, something you guys got to memorize. If they're bound on the top and the bottom here, so double binding. So the TCR binds the MHC2 on the dendritic cell, and the CD28 binds the B7 antigen on the dendritic cell as well. Then that's a normal lymphocyte. It's doing its job properly. It's presenting for an antigen. Okay, so this is not peripheral tolerance yet. Now this is peripheral tolerance. Well, let's say you have a self-reacting antigen on the dendritic cell. Now suddenly the CD28 has nothing to bind to. This TCR is still binding to the MHC2, right? It's a CD4 cell, it's still binding to MHC2. But now there's no second signal. So there's only one signal coming in. The cell is smart. The CD4 cell is smart. It goes, no B7, no second signal. All right, well, I'm going to put myself to sleep. So thankfully, the CD4 cell, it goes to sleep and doesn't attack or it doesn't, cause autoimmunity. Okay. Now now there's another thing that it can do. Okay, and this is actually I think pretty cool. Now again, no B7, no second signal. Okay, but the cell goes, the TCR is still bound to the MHC2, but I'm not getting a second signal. Why don't I cause the expression of the FAS ligand, FAS ligand? Okay, it binds to the CD95 receptor, could be on its own cell. The CD95 receptor, also known as the FAST receptor or the fast death receptor. Okay, and when that happens, it activates the caspases and everything, and you get apoptosis. The cells die. Okay, now one more step. What if the FAST ligand binds a CD95, also known as the fast death receptors, on other T cells, on other B cells? It also kills them off too, right? So again, this is just something you need to draw out a few times, and then you'll understand it. Okay. Um, this is again another disease that Dr. Sattar was important, and it actually shows up in Robbins quite a bit too. Is the ALPS. Okay, so what it is, it's a mutation in the FAS or FAS ligand or caspase 10, which is part of apoptosis. So go back to the cell. So the CD95 receptor or the FAS ligand is mutated, or the caspases that cause apoptosis. One of them is mutated, so they're messed up, right? Um, and then this basically messes up peripheral tolerance. Okay, so you get something called ALPS. ALPS stands for autoimmune lymphadenopathy. So autoimmune self-reactive cells, you get elevated IgG that destroy your own red blood cells, causing you to become anemic. You also get low. It also destroys your platelets, so you become thrombocytopenic. And then lymphadenopathy, you get large lymph nodes everywhere. Remember, if you get lymph nodes like one lymph node right here, that's not, cancerous. So you got like a throat infection or ear infection, you might get a large lymph node. But let's say somebody comes in, they got lymph nodes large everywhere. That's something to worry about. And these patients also get hepatosplenomegaly. For the sake of knowledge, I always think of the spleen and liver as gigantic lymph nodes. Okay. If your spleen is enlarged, there's something going on. You just had a mononucleosis infection, mono, and your spleen is large. And basically the spleen is like a gigantic lymph node. It has macrophages in there. And if you cut the spleen out, let's say you remove a patient's spleen because they got in a trauma or something, um, patient can still live without that one. It's not, it's like a big lymph node. So hepatosplenomegaly, always think something autoimmune, infectious, something like that. All right. Sorry, I digressed there, but I think that's an important thing. Um, Regulatory T cells. Okay, now we've talked about central tolerance. We've talked about peripheral tolerance. So now it's step 3. This is a last step on our checklist that the body can use to prevent autoimmune disorders from happening. All right, and so if this fails, you can still get autoimmune disorders. So what happens here is, again, we have the same photo of the CD4 positive um, uh, T cell with its TCR that binds to MHC2. Okay, and it's got a CD28, which should bind to B27. But this time, the regulatory T cell swoops in, has the CTLA4 receptor on there, and that binds B7. Okay, and then when it binds B7, guess what? There's no second signal. Remember how we talked about right here? There's no second signal. This no second signal happens again when you have regulatory T cells because it blocks B7. All right, and then you get energy, which means the cell goes to sleep. Also, another fact, these regulatory T cells make interleukin 10 and TNF beta. Um, Interleukin 10 limits expression of MHC2, which obviously, you can see on the top is part of the first signal, right? So obviously that doesn't work properly. And it's involved in the activation of dendritic cells and macrophages. So interleukin 10 made by regulatory T cells, T for 10. I don't know if that's easy for you to remember. And then TNF alpha, or TNF beta rather, stops the activation of macrophages. So these regulatory T cells are very important too. All right. And now let's talk about how to name them. This box that's in purple, memorize, memorize, memorize. So if you close your eyes, you should think CD4 positive, CD25 positive, FOXP3 positive. That's basically the name of your regulatory T cells. That's their long name. You know how you have a short, cute name at home? But this is the long name, okay? And the reason this is because this name kind of tells you how the cell works and what it's doing. CD4 positive, okay, cool. It binds to MHC2. You already know that. CD25 plus. Another name for CD25 plus is interleukin 2 receptor. And now you know that interleukin 2 is involved, and that allows for growth and survival of your regulatory T cells. Great. FOXP3 positive. FOXP3 is a transcription factor on which regulatory T cells are dependent for survival. Okay, so if any of those 3 things get messed up, right? If the regulatory T cell is not going to work. So in Dr. Sattar's lecture, he talks about CD25 polymorphisms. And this to me is extremely important, okay? CD25 polymorphisms, meaning your CD5 receptor has a different genetic code, makeup, looks different, right? It can lead to autoimmune disorders. So autoimmunity. So people who get multiple sclerosis or type 1 diabetes. In type 1 diabetes, that's when you have antibodies that attack the islets of Langerhans, the islet cells in the pancreas. This comes up on boards all the time, and then the person cannot make insulin, and when they can't make insulin, they get diabetes. That's separate from type 2 diabetes. Type 2, think of your big fat uncle. Type 1, think of that poor little kid at the age of 8 who got diabetes even though he's skinny and small, right? I'm generalizing, but that's kind of how you remember. It's not that little kid's fault, right? He didn't do anything wrong. So he has an autoimmune type 1 diabetes because he had a polymorphism in CD25 that led to accidentally the destruction of his uh, pancreatic islet cells. Okay. Now the FOXP3. Let's talk about that real quick. All right. If you have a mutation in FOXP3, that causes IPEX syndrome. Again, I've never seen this before. I had to rememorize this when I was going through this lecture. I forgot it existed, but it's rare. But it's a good thing to memorize because it's an easy thing to test, right? So IPEX syndrome stands for what it is: immune dysregulation, polyendocrinopathy, enteropathy, meaning you get diarrhea, and it's excellent, right? So mainly, you're going to find it mostly in men. Um, okay. And all right, so last few things, just kind of household cleanup things that you should remember. These autoimmune disorders are more common in women. Okay, it's just the way it is. Unfortunately, ladies, I'm so sorry, but you have higher levels of estrogen, which reduces the apoptosis of self-reactive B cells. So if you think back to this little chart, was in our primary or central. Let's see here, central tolerance. So if you go back to this slide in the bone marrow, right? This whole thing is messed up. Estrogen, apparently, it's theorized that it prevents apoptosis from happening of the self-reactive B cells. Another thing, unfortunately, to remember is high levels of estrogen cause a lot of problems. And I'm not going to this is not going to be on this quiz or this test, but just want you to know that obese women have high levels of aromatase in their fat cells. The fat cells aren't just sitting there. They got stuff inside. They're doing bad things, okay? And we'll talk about that in the future as well. But the fat cells have high levels of an enzyme called aromatase, and therefore obese women have high estrogen levels, and therefore obese women, have bigger periods because their lining of their uterus gets thicker, and they're also more likely to have gynecological cancers, which we'll also get to. But unfortunately, it also means that they're more likely to have autoimmune issues as well. So unfortunately, that's an issue there. And then lastly, let's talk a little bit about environmental triggers. So some people have genetically more predisposition to have autoimmune disorders. I think that's pretty obvious. It's logical. If your brother has, type 1 diabetes, you might be more likely to get type 1 diabetes than, say, some random other person, right? HLA association with HLA subtypes, PTPN22 polymorphisms. That's just something, again, you have to know. I wrote down HLA-B27. That's associated with a condition called ankylosing spondylitis. I'm not going to put this on this test, but that phrase, HLA-B27, ankylosing spondylitis, HLA-B27, ankylosing spondylitis, it just has to memorize because it comes up very common, okay? And another thing is triggers can lead to bystander activation or molecular mimicry. Let's talk about that real quick. Bystander activation, you're just hanging out, you get an infection with a virus or bacteria, and it accidentally activates self-reactive lymphocytes. Remember where I mentioned that we all have self-reactive lymphocytes, right? We all do. And let's say you have it, let's say you are HLA-B27, right? Let's say a lot of you have it. Doesn't mean you're going to get an autoimmune disorder. You need to have some kind of trigger that triggers um, you to get an autoimmune disorder. Okay, if you just hang out in a bubble, nothing's going to happen to you, right? So let's say you get a virus or bacterial infection, it accidentally might reactivate or might activate the self-reactive lymphocytes. And remember, if you only have like one or two self-reactive lymphocytes, it's not a big deal. It's like bacteria. Imagine if you have you pick up a grape from the floor or something that's dirty and you lick it. If there's like one or two bacterial cells, are you going to get infected? No, right? But if there's tons of bacteria on there, you're going to get infected. Same thing with self-reactive lymphocytes, right? So if you have tons of them, if they get upregulated because of a trigger, then you're more likely to get the disease, right? So that's bystander. Accidentally, virus, bacteria, something activates it, right? Molecular mimicry, a bacteria, virus, or something else has an antigen which is similar to a self-reactive lymphocyte. So it upregulates the lymphocytes that pertain to it and the self-reactive ones, right? So something that, like, for example, rheumatic heart disease. So when kids get strep throat, we don't actually sometimes treat the strep throat with antibiotics because we care about the strep throat. But what we do care sometimes is that if it's not treated properly, you can develop a lot of antibodies, and then those antibodies will then go attack the heart, right? And the heart has these valves, and you can get what we call rheumatic heart disease, which we'll get to when we talk about cardiac. But that's a form of molecular mimicry. You get an infection, it upregulates your self-reactive cells, and then you attack your own body by accident. That during COVID, there was a lot of talk about how, unfortunately, molecular mimicry, played a role. There was a lot of other issues, but that was something that they were thinking about as well. Okay, there's also, like, for example, if you get UV damage of your skin, you get sunspots. It can cause the cells to break. The nuclear antigens that are inside those cells then get exposed to your immune system. Your immune system makes antibodies, and then it destroys your cell, and then maybe you get cancer from that. And there's also some good research on smoking and how smoking leads to chemical modifications of self antigen, and that's how a lot of smokers get like rheumatoid arthritis. So we'll get to all this, but just know that this is kind of important. That you're even if you have a gene that says, hey, you're screwed, you're gonna get autoimmune disorders. It doesn't need to happen unless you have a catalyst, unless you have an environmental trigger. Lastly, I thought this was a great slide by Dr. Sattar. Um, Most autoimmune disorders are clinically progressive, right? The antigen never goes away, and so you're going to get relapse remission, meaning it flares up, goes away, flares up, goes away. And that's how my psoriasis is. Sometimes I'm fine for months and months and months, and then some days I just can't move my hands, and it hurts and it hurts and it hurts, and I complain and I complain, right? And usually, it gets worse with time because there's more and more. It's not like the antigen goes away, so it just kind of builds up. And then also, when we're on the next chapter, we're going to talk, or the next section, we're going to talk about how all these different autoimmune disorders, and you're going to look at them and go, these all sound very similar. They have a lot of things in common. And one of the reasons it's a theory is something called epitope spreading. It is a hard concept to explain, but the way I think of it is, let's say the autoimmune cells destroy some tissue, right? They destroy the tissue, and boom, it blows up, and now there's more stuff that's exposed. Now your body comes in, makes antigens to those things that are exposed. Boom, it goes somewhere else, destroys that by accident. Then even more antigens there's more antigen exposure, and then it just gets bigger and worser and worser, right? And it attacks a lot of similar areas that are very susceptible. So a lot of diseases, therefore, have very similar overlapping features, and sometimes are annoying to memorize. Okay, guys, I hope this was helpful. I would watch Dr. Sattar's lecture first and use my slides as a kind of like an aid. Okay, there's nothing in here that's not also in his lectures that I'm going to be testing you on. Okay.